Thank you, sir. Thank you, the esteemed panelists, and it is my great pleasure to present this study in front of my teacher, Professor Moharuf sir, and others. And it's a single center study in our center, Bangladesh Specialized Hospital, where we work. We are trying to evaluate the success of current standard of care of breast cancer treatment, and I'm also glad for our all co-authors. So this is a disclaimer. This retrospective observational study was supported by Novartis Bangladesh Limited. And as we all know that the global burden of breast cancer is very high, and the leading cause of cancer-related mortality and morbidity among women accounts for 25% all new cancer cases in women worldwide, as well as 2.3 million cases and 685,000 deaths reported in 2020. Survival disparities exist between high income and low income, low and middle income countries. There is a lot of disparities. And what about the breast cancer in Bangladesh? Most common cancer as well, and among Bangladeshi women with a rapidly increasing incidence, and mortality of case diagnosed at the advanced stage, leading to poor survival outcomes. And late-stage presentation due to the low awareness, sociocultural barrier, and lack of national screening program, limited access to specialized oncology care and advanced treatment options. So what is the unmet need in breast cancer treatment? We can challenge in the breast cancer management because there is a lot of challenge, is consistent adherence in evidence-based treatment protocols. Mastectomy remains the dominant surgical approach due to the limited expertise in the breast conserving surgery. Lack of national treatment guidelines leads to variability in patients' care, and molecular subtyping is unutilized, affecting personalized treatment strategies. So need for real-world data and research. That's why we are trying to access or evaluate, as there is limited data on progression-free survival and overall survival in Bangladesh. Research gap hindered the treatment optimization and policy development. And incorporation of progression-free survival metrics into routine practice could enhance treatment evaluation and decision-making. So this study overview, it's a retrospective study, and it happens in the Bangladesh Specialized Hospital Department of Oncology. The period is quite high. 2018 to 2023, and the objective is evaluate the success of current standard of care of Bangladesh breast cancer treatment in Bangladesh. Data source is all collected from the hospital information system, and the inclusion criteria was 18% older confirmed breast cancer diagnosis patient, a patient who followed national and international treatment guidelines, and exclusion criteria was patient with incomplete medical records, those who did not receive treatment as per standard guidelines, and ethical consideration was taken, and data analysis was conducted with SPSS 26 version. So this is the baseline characteristics. We have a total number of patients, study participant predominantly female, 98.99%, and only 1.1% male, that is identical, and among them the most participants are aged 50 to 59. But I would like to highlight this area, that is 30 to 39%. There is 9.1% or around 10% patient has below 40 of age, which is very much not identical with American Cancer Study data. The majority are married, with 13.4% were unmarried, and most participants had men are between 11 to 15 years of age. So the BMI distribution also we try to find that is there any relationship between the obese or not. So we only find 27.3% overweight, and the risk factor were infrequent. Hormone replacement therapy is very few because of the cultural, maybe the reason we are not mostly use the hormone replacement therapy, and family history of breast cancer is also evaluated 3.7% or around 4%. Comorbidity also checked. So this is the tumor characteristics. If you see that, as we know that left-sided breast are dominant, and we have a significant number of bilateral breast cancer, around 7%, and left-sided 50.4%, that is 549 cases, and right-sided is 42.5%. But if we see to measure the stage-wise global data and our patients' data, we can understand that we have global patient has a good number of stage 2 patients, 34.6%, whereas we have a higher number of stage 3 patients, that is 31.8%. So this disparity, we can understand that we have a lot of cases presented with locally advanced breast cancer. This is an alarming thing. Maybe it's a pointing thing that the stage 4 patients are very less in our institute. Maybe because of, I don't know, maybe the initial stage 4 patient really comes always in our center. That is maybe one point. So if we see the clinical stage, we try to subdivide the clinical stages. Early stage patient, it's a quite good number, as well as advanced stage. But the patient who are follow up during the course of time, we see that 45.4% are become metastatic in the course of their follow up, whereas the stage 4 patient was only 1.8%. And if we see the tumor characteristics, it's very obvious that we have a good distribution of grading, and the invasive ductal carcinoma has 61%, where the lobular carcinoma is 15.9%. And I will highlight this slide and give you the attention to this slide as well, because we try to compare the American Cancer Society data, where we find that hormone receptor positive or luminal A case has 68%, but we find that it is 39% in our study group population. And important difference between American Cancer Study and we have that TNBC is a predominant case in our patient group, that is 23%. And if we combined with the HER2 case along with the luminal B group, it is around 21.4%. That is also higher in compared with the American Society. Maybe this is the reason, another reason of the low inclusion criteria, inclusion of our patients' number. And the treatment protocol also overlapping, and it's 50.5% patient receive radiotherapy, 40.4% patient receive chemotherapy, and 30.3% patient hormone therapy. And a good number of patient has a, most common has a lumpectomy, that is 38.9%, followed by the second most is mastectomy. But there is a shift here that we can see that we are going a lot of lumpectomic patient right now. Along with the sentinel biopsy, we have 7.8% cases where the 3.5% under axillary lymph node dissection. I may be here this all information of surgery is not included. That's why maybe this is quite less number. So if we see the results of progression-free survival, 27.7% participant had a stable disease with a median progression-free survival of 407 days. And disease progression occurred in 4.4% of the participants who exhibit significant lower median PFS, that is 75 days. The majority of patients, around 67%, were censored, indicating no progression at the time of analysis, with a median progression-free survival of 866 days. So high loss to follow-up and mortality led to 67.8% censored data, with a median progression-free survival of 866 days, affecting outcome assessment. And this is the Kaplan-Meier curve of our total groups, and this pattern underscores the variability in patients' outcome and highlights challenges in the tracking disease progression in resource-limited settings. This is the overall results of the luminal criteria. If we say that luminal A patient exhibits the most common favorable prognosis as we expected, maintaining a high survival probability of 68.6% of at 365 days. Luminal B, that is luminal B with HER2 positive show a strong early survival, but declined 57.8% at 365 days. And luminal B HER2 negative starts with the 100% survival at 30 days, but drops significantly 47% in 365 days. TNBC and HER2 positive subtypes demonstrate the poorest survival outcome, as we already know, but TNBC show better than the HER2 positive alone. And this is the relative risk of event. Luminal is the most favorable prognostic factor, as also seen. And what is the limitations of this study? This is single study biased. Definitely, there might be some bias. And incomplete data loss and data and loss of follow-up, limited molecular biomarkers data, though we have seen that most of our patients underwent luminal criteria except 7.7%. Heterogeneity in the treatment modalities and lack of national representation needs survival analysis constraints. So what could we recommend through our studies? That we can implement a nationwide screening program, which is not established yet in Bangladesh. Developed standardized treatment guideline. We, from our society, we have tried quite long time ago to go for the metastatic hormone receptor positive guideline. We believe we can do it one day. And enhanced molecular testing facilities. As we see right now that ERPR and HER2 is not only the only biomarkers to after 2 years or progression of the hormone receptor positive cases. So we have to find out the other mutations with the gene analysis and try to develop the new genetic labs. And expand oncology workforce and infrastructures and strengthen research and data collection and tailor treatment approach by subtypes. It's very important to, because we are our patient is taking care of their treatment by their own pocket, and improve patient awareness and education. And by addressing these challenges and implementing targeting interventions, we can improve breast cancer outcome, reduce mortality, and bridge the disparities between resource-rich and resource-limited settings. And thank you for your patience hearing.
Thank you, Dr. Arifur Rahman, for your excellent presentation.